You sent labs?
No indication, normal vitals, normal neuro exam. Dude just dropped, no warning.
What's open?
Trauma 1.
Grab Langdon or whoever else is available.
What do we got?
Seizure in chairs.
Thank you. How is it out there?
Chaos. We're never gonna catch up.
As a continuation of the previous episode, this patient was having a seizure in the hallway. The first thing to note here is the froth coming out of his mouth, a typical feature of seizure. However, the most important thing to note here is that the patient is still having convulsions continuing till now since the hallway, and still there is rhythmic jerking of his limbs. This is a very bad sign because if this lasts for more than 5 minutes, the patient is said to have gone into status epilepticus. Status epilepticus is defined as a seizure lasting more than 5 minutes or recurrent seizures without recovery to baseline consciousness between the episodes, meaning if the patient has 2 or more episodes and remains unconscious in between. This is a life-threatening neurological emergency because prolonged seizures can cause permanent brain damage. So here, immediate seizure control must be done. Here, put the patient immediately in oxygen, open up an IV access, and provide IV benzodiazepines like lorazepam.
Lorazepam's on board.
Okay, drop another 4.
The first-line drugs for acute control of status epilepticus are drugs like lorazepam or midazolam. Sometimes, opening an IV access in an actively seizing patient is a huge challenge, and time is brain. So, we don't wait for that and provide intramuscular midazolam 10 mg stat if IV access is difficult or takes time. We would then typically use other second-line drugs as we go if this isn't controlled by lorazepam or midazolam initially.
Yeah, no history. Doesn't look like he's been here before.
Starting low 90s on 5 liters.
If the patient has progressively decreasing oxygen saturation during seizure, it could indicate airway obstruction. Now this could be due to tongue prolapse, secretions buildup obstructing the airway, could be indirectly hinted here by the froth coming out of the mouth, or just hypoventilation as the respiratory muscles can fatigue during seizure. So we gotta secure the airway here and provide enough ventilation, maybe change the nasal prongs to a non-breather mask as per necessary. The point here is to not delay airway management waiting for seizures to stop.
Another 4 milligrams?
Can't get the top off.
It's just the plastic, not the...
No, I know.
Here, give it to me.
No, I got it.
Okay.
Regarding the dose of lorazepam here, it's 0.1 milligrams per kilograms IV and maximum 4 milligrams can be given per dose. Here, it's going to be repeated twice already.
Ordering CBC, CMP, and a straight cath for urine tox.
We gotta understand here that status epilepticus can be caused acutely due to stroke or CNS infection or head trauma or even electrolyte abnormality, so full blood workup is a must including CBC, CRP, or C-reactive protein if infection is suspected, along with CMP or comprehensive metabolic panel which includes glucose, electrolytes like sodium, calcium, magnesium, liver function tests, along with tests for renal function. A toxicology screen is very important because this could also be due to drug overdose or alcohol withdrawal or accidental ingestion. Urine toxicology screen is the most commonly used as it's quick and detects drugs or their metabolites excreted in urine. A straight catheter, also known as an intermittent catheter, is used to collect a urine sample for toxicology testing when a clean catch urine sample is not possible. It's called in and out catheterization because it's a one-time sterile method to obtain a urine sample without leaving a catheter indwelling like a Foley's catheter.
Pushing the second 4. If this doesn't work, we need to prep Keppra.
Keppra is the brand name for levetiracetam. So if lorazepam doesn't work, there are drugs that can be given like fosphenytoin, sodium valproate, or levetiracetam. These are anti-seizure medications given intravenously as second-line drugs for seizure control in status. Now, if even these fail to control seizure, we gotta start intubation with general anesthesia with either midazolam infusion or propofol infusion or thiopental infusion. At this point, it requires continuous EEG monitoring and ICU care. I've seen a patient who had to be on an infusion of midazolam because his seizure wasn't controlled by lorazepam or levetiracetam and the seizure lasted for more than 30 minutes. It's really a dangerous sight to behold both for doctors as well as for the patient party if the seizure isn't controlled immediately and patient continues to seize again and again despite providing medication for it.
No, we'll give more lorazepam. It's already ordered.
He's already had 8 milligrams. He'll stop breathing.
Then we'll intubate. Sometimes the patient needs a little more.
The girl is actually right here. We can repeat 4 milligrams of IV lorazepam, that too once, after 5 to 10 minutes ideally, if seizure persists, and the patient hasn't responded, so maximum total dose would be 8 milligrams in most adults. If seizures are continuing after 2 doses of lorazepam, we shouldn't keep giving it repeatedly after that, as there is risk of respiratory depression. The benzodiazepine drugs like lorazepam or midazolam can cause respiratory depression, and the patient could go into apnea if higher doses are administered sequentially, and yes, that might require intubation to prevent respiratory failure and hypoxia due to benzodiazepines. So, if seizures continue after 2 4 milligram doses of lorazepam, switch immediately to a second-line anti-seizure medication like fosphenytoin, sodium valproate, or levetiracetam.
How long has he been seizing?
About 4 minutes ago.
We know the significance of timing of the seizure here. If it's more than 5 minutes, the diagnosis of status epilepticus is made, and we are treating it as a case of status already here.
He started seizing in chairs. He's already had 8 of lorazepam. I want to move on to Keppra, but Dr. Langdon disagrees.
Just want to try another 2 milligrams before moving on.
Not only does the risk of respiratory depression rise sharply after 2 doses of lorazepam, but also it becomes ineffective due to desensitization of GABA receptors, which is basically the site of action for these drugs. If 8 milligrams didn't work, in theory, adding 2 milligrams is unlikely to make a difference, as benzos lose efficacy over time due to GABA receptor internalization. More benzos mean more sedation but not more seizure control, and more sedation means more risk for hypoventilation and apnea. Let's see what happens here.
Dr. Langdon's patient, Dr. Langdon's call.
The girl can't do anything here except complying to the senior's order, even though she is reasonable here. And honestly, the optimum dose for anything varies according to the treating doctor, as every doctor has different experiences with the patient and drugs. Dr. Langdon might have had a patient controlled before with higher doses of lorazepam than the protocol says, and hence he's insisting for it.
Dennis Whitaker. Meet Bob Chazen, a 53-year-old cyclist who injured his leg about 10 days ago on a trip to Utah.
I was in Moab, coming downhill fast and jammed my pedal into my leg.
Ooh, ouch. It's some gnarly road rash.
White Rim Trail. I've been putting Neosporin on it a couple times a day.
Basically, a case of wound like this would require first cleaning the wound with normal saline or betadine, removing dead tissue around the wound area if necessary, which is called debridement, and then putting on antibiotic ointments like mupirocin or neomycin, and then dressing.
Hey, but now it hurts to walk.
What do you see, Whitaker?
Outside of the wound looks cellulitic.
Cellulitis simply means bacterial infection involving the skin and subcutaneous tissue. This means that the wound has been infected secondarily with bacteria after the injury and needs antibiotics and pain meds as well as adequate rest.
What's that?
It's a bacterial infection. We'll need to get you on oral antibiotics.
Figured.
What about the center of the wound?
It's a simple hematoma.
Which you can now debride.
Hematoma means collection of blood caused due to rupture of a blood vessel wall. Debridement, or removing dead tissue, is important because dead tissue acts as a barrier to the healing process of wound and provides a breeding ground for bacteria, further complicating the infection here. Removing this will allow healthy tissue to regenerate for healing of the rest of the wound. We often used to extensively debride wounds of burn patients who are admitted to the surgery ward all the time. It promotes faster healing and provides clean environment for wounds to heal.
Whitaker will take off the dead skin covering the blister to help it heal better. I'll be right back.
Yeah, quick question.
Get some iris scissors, tooth forceps, sterile gauze.
No, it's just, blister guy? Really?
Mr. Chazen was the next patient on deck.
I know I screwed up earlier.
You didn't screw up. Patient died. It happens.
This is not an uncommon feeling to have, especially if you feel like you've screwed up before, to think that the senior is now going to punish you or make you work more or won't give you better or quote-unquote cool cases to work with in the future. Here the guy hasn't really screwed up. It wasn't his fault that an unstable angina patient who was in the hallway with no way to diagnose him suffered from sudden cardiac death due to angina progressing into a myocardial infarction and then cardiac arrest.
Just don't amputate Mr. Chazen's leg.
Amputation simply means surgical removal of a limb or a part of a limb, usually indicated to prevent further complications to the rest of the body due to the infected or diseased or injured limb. Here there is no such thing at all, and it's meant as a joke because amputation is a very delicate and meticulous process that would require full-blown surgical setting and expert surgeons to do it. I remember the time we as interns used to be given cases of extensive foul-smelling wounds with pus inside for dressing. None of the seniors used to do it, and it did feel like they were avoiding them by giving us such cases. One of them was an amputated leg, where the site of amputation just never healed clean and was chronically infected with loads of foul-smelling pus.
Hey.
Another 2 of lorazepam.
For a total of 10.
I'm well aware.
As said before, with such high doses of lorazepam, respiration needs to be monitored very well. But the problem here is that the patient is still seizing. It's important to stress here that continuous seizure can permanently damage the brain.
He's still seizing. Call respiratory. I'm setting up an intubation chair.
Which he won't need.
Intubation while the patient is in status epilepticus is an interesting consideration. As we all know, intubation is all about securing the airway and ventilating the patient to minimize the work of breathing and bring back oxygen saturation. But here, the patient is seizing and it's definitely a challenge. We gotta anesthetize the patient first with general anesthesia before that. Now, the protocol for management of status does include general anesthesia as a last resort. Here, the patient has been given first-line drug lorazepam and the seizure hasn't stopped. The next best step would be to provide a second-line drug like levetiracetam, fosfenitoin, or valproate. If seizure still persists after that, we call it refractory status, in which case general anesthetic infusion has to be considered to sedate the patient with drugs like propofol. At this point, we have no other choice than to intubate the patient. So, in this case here, we've just repeated the first-line drug. The response has to be assessed over 5 minutes. Then if not, second-line drugs are still pending, so intubation need not be considered immediately here. Let's see.
Dr. Santos, what is the definition of status epilepticus?
Is this gonna hurt?
Oh, no. Skin's dead. You won't feel a thing.
We could give local anesthetics like lidocaine injection around the site before debridement to numb that area.
Oh, whoa, oh, oh! Do something, man! Dude! Whoa!
I need a little help here! Jesus!
So, an arterial puncture bleeding during debridement of wound does take place when an artery underneath gets cut or a cut artery gets exposed while trying to cut the dead tissue above. Immediately, we gotta apply direct pressure using sterile gauze to control bleeding. We typically keep layering more and more gauze and maintain pressure. We could also use topical hemostatic agents like Surgicel as well. Once bleeding slows, we could apply a firm pressure dressing to maintain hemostasis. If bleeding remains uncontrolled or from a deeper artery, then immediate vascular or surgical consultation is necessary to explore and manage it in a surgical setting.
Hey, what's up?
Arterial pumper under a blood blister.
Let's see.
No, never remove the gauze like that. And if you do, please remove it while you are beside and away from the puncture site.
Oh, Jesus!
Okay.
Noob.
Hi, I'm Dr. King, and we can fix this.
Did you cut an artery?
No. I punctured the top of the blood blister, but there's an artery hiding under there.
Which does mean he either accidentally nicked an artery underneath with the scalpel or maybe exposed it by puncturing the said hematoma. It happens. But it's important how you deal with such situation. Don't appear like you don't know anything even if you actually don't know anything. That's a really bad look for yourself in front of the patient who wouldn't trust you with anything after that. Calmly assess the situation. Don't start panicking in front of the patient. Otherwise, why would the patient not panic if his treating doctor is panicking himself?
Hiding? Like you didn't know it was there? Don't you have to know basic anatomy to become a doctor?
I don't think patients would utter the word anatomy. Also, it's not that he didn't know anatomy, it's just that he didn't handle the situation well in front of the patient.
He's a student doctor.
What the Student? Oh, hell no. No. Can you help me? Can you fix it?
Oh, absolutely. First, we are going to put this BP cuff on to stop the bleeding. A little forward. There we go.
The tourniquet method is applied here to temporarily stop the bleeding. Here, a BP cuff is applied proximally to the wound. Then, the cuff is inflated to pressures above the systolic pressure of the patient to temporarily stop the arterial flow to the limb by compressing all the major arteries. A common guideline is to inflate the cuff to a pressure of systolic blood pressure plus 50 for the upper limb and systolic blood pressure plus 100 for the lower limb. This high pressure is sustained there. This would cut off the arterial supply to the wound altogether and stop the bleeding. However, we gotta note the time of application. It should be released within 30 to 60 minutes to avoid ischemic injury and tissue damage to the limb due to lack of blood supply.
All right, you can let go.
Yeah?
Mm-hmm.
Thank God.
Oh, thank God.
All right, Whitaker, 10 cc's of 1% lidocaine with epi.
Yeah.
This is lidocaine mixed with adrenaline used here as local anesthetic. The addition of adrenaline is important as adrenaline is a vasoconstrictor, so it does help decrease bleeding by vasoconstricting arteries and help provide a bloodless operating field. They are probably going to inspect the wound and suture the bleeding site if possible.
The shot is going to numb the area and also constrict any blood vessels so that we can put a little stitch in there.
What happened in here?
Arterial under the vesicle.
An arterial means a small caliber blood vessel, often just beneath the skin, and can spurt blood like this.
Bleeding stopped at 180 on the BP cuff, and we are now injecting lidocaine with epi.
Thank you, Dr. King. Let's set up a suture tray with 3/0 nylon.
This means they are going to suture the punctured wound site with the suture material nylon 3/0.
Okay, a pinprick and some burning.
Doc, can you step in here, please?
You got this, Whitaker.
It's very difficult to gain trust of a patient once you've appeared in front of the patient as having lack of knowledge or skills necessary to treat them, even if you actually have enough knowledge or skills.
Slowly letting down the cuff pressure until we can identify the exact spot.
Deflating the cuff and calibrating the pressure down to a minimum level enough to stop bleeding is important here because you don't want to inflate it to a very high level that would cause ischemia or irreversible damage to the entire limb while trying to stop bleeding.
I see it, right there.
Okay. Now you can place a figure of 8 suture.
I've never done one of those before.
Again, don't tell that in front of the patient because I bet no patient wants to hear that his doctor doesn't know. The figure of 8 suture is a suture technique for controlling bleeding and achieving hemostasis in cases like this. Here, first enter the tissue on one side of the wound, pass the needle across to the other side, then re-enter on the same side as before, slightly adjacent to it. Cross the wound again. This forms a figure 8 pattern. If the bleeder or the bleeding arterial is visible, we can pass the needle around the vessel in a figure of 8 and pull tight to compress and tie off the vessel. Now tie the suture firmly over the wound, and this will seal the wound as well as compress the bleeding arterial and hence control the bleeding.
Look, maybe you should just do it.
You should definitely do it.
Whitaker's got this. It's easy. Just 2 stitches.
It could be said as that because here, instead of just tying the suture after the first bite, you go on to take the next bite with the same thread and then only tie it.
1. Take a big bite, a simple interrupted suture, anterior to the bleeder.
Okay.
Seizure lasting more than 5 minutes or at least 2 seizures without full recovery in between.
Excellent. Seizure activity is stopped.
So, a little bit of extra lorazepam above the maximum limit actually worked here. In real life scenario, it is important to note that while this might be done based on the experience of the treating doctor, I have seen a case in the ICU where a patient who seemed agitated and causing a bit of trouble was given a little bit of IV midazolam, which was in the already loaded syringe by the nurse in charge without consulting the resident doctor. Here, the patient actually went into respiratory depression and apnea, and we were called immediately. We started CPR, but to no avail, and sadly, the patient who was actually improving in the ICU died.
Also excellent. Spontaneous breathing, good tidal volume.
Tidal volume basically means the amount of air inhaled or exhaled during a normal breath. Its range is from 400 to 500 milliliters and is measured via spirometry. Here the doctor means to say the lungs have fully expanded and there is good air entry and exit as per auscultation of the chest areas. It's important to note this because during status epilepticus, respiration is compromised with hypoventilation or apnea, and there is compromised air entry to the lungs and poor lung expansion.
Sats up to 98.
Welcome back, Mr. Marino. Now we can do a Keppra load slowly and safely.
Keppra load can be given after status to prevent the seizure recurrence. This becomes important here now because status has a high risk of recurrence. Besides, levetiracetam is a safe drug to use. It provides minimal sedation and can be transitioned easily to the same dose oral later on.
Nice work, Dr. Langdon. I will be at Central if you need me.
This must have been a bad vial. 8 milligrams should have worked.
According to your textbook of emergency medicine, but sometimes they need a little bit more.
Medicine is all about experience, not textbooks. Even though textbook deductions and protocols are the standards to follow, administration of drugs in the recommended doses sometimes do not bring about the expected clinical outcome. And a little bit of dose adjustment is pretty common, and it also varies according to the patient too. While this patient required a higher dose for control, status epilepticus of the next patient may immediately respond to just 4 milligrams of lorazepam as well. So medicine is unpredictable, and we do make practical deductions like Dr. Langdon here as we go and as we come across more cases, sometimes contradicting the standard protocols a little bit.
Or you'll learn that with time.
But why couldn't I open the vial?
Because you're an intern. Who also needs to learn to trust her senior resident, especially in front of an attending.
Yeah, so her telling Dr. Robbie about the resident's decision sounded so wrong. Like, how could you complain about a senior's decision to another senior in front of him? That's pretty disrespectful. And I don't think this really happens in real life. We don't try to override a senior's decision in front of an attending. The best we would do here as a junior is ask why, and maybe the senior would talk about his past experiences with patients that influenced his decision now. That's it.
Now, check his labs, babysit him until he goes to CT, and get some blankets on these side rails as a seizure precaution.
This ties up perfectly with the causes of seizure we discussed before. There could be a stroke or mass or traumatic lesion in the brain. To rule out all of this, CT head in case of seizure is very important. Additionally, along with all the blood investigations already sent, a lumbar puncture could also be done if CNS infection is suspected like meningitis.
Got a second?
It's never a second, but shoot.
I think there was an issue with a vial of lorazepam used on our last patient, and it should be reported to the drug manufacturer.
What kind of issue?
The cap was really hard to take off, almost like it was super sealed shut.
I mean, it's easier to accept that you don't know everything, and it's fine to screw up sometimes, rather than just complain about how everything isn't perfect. In fact, most of the things aren't textbook perfect, and it's not a big deal.
I'm worried it could be a bigger issue.
Like
Maybe the temperature wasn't properly controlled during transportation and the seal on the vial melted shut, which could mean the medication is compromised.
This just means she can't still accept the fact that the patient's seizure didn't stop with 2 doses of lorazepam as per the guidelines, and is blaming the vial or the drug stored in it to be ineffective. It's easier to understand how every patient's body responds different to medications, rather than think that the medicine is somehow defective here.
Any other vials affected?
Just this one.
Okay. Check the manufacturer's website, see if there's been a recall of the lot number.
And what if this is the first regular vial?
Then hold on to the vial in case there are any other issues.
The resident is fed up with the intern trying to be smarter than him at this point here.
Little advice, man to man. Always compliment her outfit, hold her hand in front of your friends, and always wrap it before you tap it.
Okay.
Just wanted to add this scene here. I love how this series tries to include medical aspect in every scene and educate.
Now instead of tying, through another one posterior. Looks good. Now a normal tie for a figure 8.
Also, the suturing scene looks way too real. It looks like the thread is actually passing in the wound of a real leg. It shouldn't be, right?
What did I miss in here?
I am so sorry. I just
Made an excellent catch and saved Mr. Chasen's life.
Really?
Really?
There was a cut arterial under a blottable vesicle.
So, the possible explanation for this could be that there was an arterial underneath a vesicle or hematoma that was already cut, and hence the formation of hematoma in the first place. The bleeding from the arterial had likely been stopped due to the tamponade effect of the blood above it or due to clot formed. Upon nicking the vesicle here, the blood got released, and hence the tamponade effect also got released, or the formed clot got dislodged, and the arterial started bleeding again.
If Mr. Chasen had gone home without debridement, the blister could have eroded with uncontrollable hemorrhage.
Nice work. Jackson Pollock here might want to go hit the Scrubs Exchange.
Yeah.
It was bound to happen sooner or later, as the definitive management here is ligating the artery and the bleeding wound, done here by suturing in a figure of 8. A patient with an IV catheter in his hand and fluids who was in the hallway? Is this because there are no beds for him upstairs? That's an indication of severe bed deficiency in the hospital here.
All right.
Next up is an ingrown toenail.
An ingrown toenail, also called onychocryptosis, happens when the edge of the toenail grows into the surrounding skin, usually the big toe. This causes pain, swelling, redness, and often infection as well. This usually occurs due to improper nail trimming, like cutting nails too short or curved, or with tight shoes, or trauma to the nail. Management would include warm soaks with salt or antiseptic solution. We could gently lift the nail edge with a bit of cotton and apply topical antibiotic ointment. We might require a partial nail avulsion, which is a minor surgical procedure to remove a portion of the nail.
It should be pretty quick though. And, Sherry, you're back. The kids get to school okay?
Yeah, thanks.
Okay, cool. Well, come with me and we'll finish up your wound care, okay? Earl, what are you doing out here?
I'm hungry.
Head back inside and we'll get you a sandwich.
No egg salad.
Okay, so this is an inpatient who fled.
Sure.
Excuse me. I've been here for over 5 hours, okay? Way longer than that chick. Can you check the list? Driscoll, Doug, Driscoll.
Just a quick comment here. I have actually seen patients fight and almost coming to blows over who wants to get in, even in the outpatient department where I was seeing patients.
Everybody is seen as quickly as possible and in order of medical care needed.
Unless they die waiting.
Just to avoid this, there is the system of triage, where the patients are assessed initially to order them in the priority of care, whether they need urgent care or whether their care can wait, while the critical patients get care first.
Would you look at that, Mr. Driscoll? It's actually time to bring you back.
Thank God.
Would you take care of Mr. Driscoll? Yeah, absolutely. Sherry, you're with me? Oh, yeah. Yeah, let's take care of this.
Can someone please help? It's my mother. She fell.
What happened?
I fell in the yard, hurt my arm. That's all.
Yo, we've been hugging this wall for almost an hour.
Relax. We're just gonna take her vitals.
Oh, Mom, got cuts all over. I fell in the rose bush. I'll be fine.
I'm Dr. King. This is Perla. What's your name?
Ginger Kitajima. I'm her daughter, Rita.
Ginger, did you hit your head?
No.
Any chance she could have fainted?
I told you, I tripped. I was taking a shower and she went outside. She's not supposed to go outside anywhere without me. She needs 24/7 assistance with ADLs.
A case of fall injury here. ADLs, or activities of daily living, mean self-care tasks essential for independent living like eating, bathing, dressing, and mobility, all of which are likely taken care of by her daughter.
Are you the primary caregiver?
I'm her only caregiver.
Ma'am, what medications are you on?
Oh, just one. Risperidone.
Risperidone is an antipsychotic drug used for schizophrenia, particularly an atypical antipsychotic drug, the same class as the drug olanzapine, which was used on methamphetamine-induced psychotic patient Kraken before. This means that the mother has schizophrenia or psychosis.
My mom has schizophrenia.
Schizophrenia is a specific chronic psychiatric disorder that includes episodes of psychosis. But psychosis is a broader term that can be caused by conditions other than schizophrenia, like drug use.
BP 132/78, pulse 84, sats 98.
Haven't seen this young lady around before. Somebody new.
Flattery will get you everywhere.
Ground level fall, good vitals. No head trauma, no AMS.
AMS means altered mental status, which refers to a change in a person's level of awareness, understanding, attention, or consciousness.
And just an isolated shoulder injury.
You have any pain in your belly?
No, but next time buy me dinner before you do that.
Okay, let's order some basic labs and get some pain meds on board and call me when the x-rays are back. Your mom's in very good hands.
For a case of fall injury, here it's unclear whether she fell on her head. We gotta assume that it's the case here since history is unreliable, and order a CT head as we wouldn't want to miss any traumatic injuries to the brain here.
You're leaving so soon?
Oh, I'm never far away.
I'll save a dance for you.
I'll be counting on it.
Looks like more than just vitals to me.
That's it. You're on the list, Hurley.
No. Perla, I'm sorry. I take it back.
Too late. You're on the list.
I like big butts, and I cannot lie.
Whoa. You scared me there.
Want a pony ride, big boy?
What?
Excuse me, Myrna. I need to discuss a confidential patient issue with my colleague here. We need a little privacy.
Catch you later, sweet cheeks.
Don't mind Myrna. She's harmless.
She's handcuffed.
That's why she's harmless.
Sure, she'd probably be all over Dr. Robbie if she wasn't handcuffed. I do wonder what the patient is suffering from and why she is in handcuffs. Is she a patient under arrest who needs medical care so has been to the ER or something? But again, she seems to be a regular here, and everybody already knows her. Let's see.
That kid looks my age.
Yeah, he is.
What happened to him?
Stressed out 18-year-old took some pills off the internet to help him sleep. They were laced with fentanyl.
Is he gonna make it?
If you haven't seen the previous episode breakdowns, this was the patient who overdosed as he took a counterfeit Xanax pill to help with his sleepless study nights that happened to contain fentanyl. Fentanyl caused enough respiratory depression and hypoxia to permanently damage his brain and brainstem, and hence, he couldn't be rescued by the antidote naloxone and is now brain dead. He's taken for the brain perfusion scan, irrespective of the findings of which he is still brain dead.
Poor Huckleberry. Not even 11:30 and you've already been demoted.
I only had morgue scrubs left in my size.
And I guess you better not fuck anything else up today, huh?
Why is there always a person as a colleague who thinks they are the best or the smartest and want to show off their unwanted and oftentimes unjustified attitude towards normal people?
What can I do you for?
Hypothetical question. Would you ever go over a resident's head to the attending?
Hypothetically, I wouldn't recommend it unless it's a behavioral issue or harassment. And in that case, you can make a confidential report to HR.
What if it's more patient care related?
Depends. If it's something minor, leave it alone. If it's something that endangers a patient, then definitely yes.
Why would you want to pick a battle with a resident when you are an intern? Medicine is all about experience, and the experienced one knows better than the junior. Period. No matter how smart you think you are or how much more medical textbooky knowledge you have, the experience wins every single time. This is just disrespect to Dr. Langdon at this point.
Pick your battles. You don't want to be the intern who cried wolf.
We, as interns, used to be sometimes angry with the residents because some of them used to make us work all the time, even making us do stuffs that aren't really related to medicine at all, but we never were angry with the residents because they outsmarted us. I mean, they are supposed to know more than us. That's why they are the residents. Some residents are condescending to interns, and I understand that completely. But what's Dr. Langdon's fault here? He seems to be a pretty good guide to the girl who is hell-bent on not being open to newer perspectives, despite almost causing a patient's death due to her own negligence and not informing Langdon about her ordering BiPAP for pneumothorax.
Yeah. Okay, still pretty raw.
Yeah.
Let me put some more anesthetic on there, numb you up some more.
It's my own fault. I should have known better than to try to make s'mores over a sternum.
So this is the burn patient that fled in episode 4 and now has returned for dressing.
They kept asking. So.
Yeah, the things we do for our kids.
Yeah.
Yeah, they must have some pretty fancy McDonald's up there in Shadyside. Yeah. That's where you live? It's the address on your patient file?
Well, technically, no. I just use the address so my kids can go to a decent school.
Right.
I know it's illegal, but it's just temporary.
Oh, God. No judgment here. My son always comes first no matter what.
Yeah.
Even if it means I have to do without. I know I'm a doctor, right? How bad could it be? But I used to be an addict. Even lost custody of my kid.
A very interesting revelation here, and that ties up perfectly with the scene showing an ankle monitor before, which is often ordered by a court or law enforcement agency. The ankle monitor allows authorities to track someone's location in real time or ensure they stay within or outside certain areas. Regarding doctors and how bad it could be, doctors are normal people, and I would bet they go through even more because of the tight schedule, the stress of the work, burnout, and less family time, breeding and brewing even more of such personal issues.
Huh. I never would have guessed.
Yeah. I went through some really dark times before I finally got help. And I've been sober now. 9 years, 5 months, and 11 days.
And your son?
He's good.
Okay.
You know, we're good. He gets to stay with me every other weekend, and we'll be back to joint custody just as soon as I get this stupid thing off next week.
Ankle monitors are used as a form of supervised release, often in place of or after incarceration. Usually, common scenarios would include pretrial release or house arrest. Wearing an ankle monitor means you're under legal supervision with restricted movement and is subject to tracking at all times. Violating rules such as tampering with the device or fleeing outside the zone can lead to arrest, jail time, or additional charges.
Don't worry, I only killed 3 people. Oh God, I'm kidding.
I'm kidding. I'm sorry. It was a bad joke.
The whole thing was just this giant misunderstanding. I guess I'm oversharing because I want you to know not everybody has it all figured out all the time.
Yeah, especially not a doctor, contrary to popular belief.
Yeah. I'm struggling. And I feel like such a bad mom. And every day is so hard. And I don't know what's going to happen tomorrow or the next day. Sometimes I wonder if they would just be better off without me.
Oh, so is this suicidal ideation? Needs further evaluation of mental status, I guess. Let's see.
Yeah. Do you?
Not like that. I've just messed up so much.
Yeah.
I don't know.
You're their mom. You love them, and nothing and no one can replace that.
Yeah.
You deserve a little grace. You know, be kind to yourself.
We, as medical professionals, deal with human emotions all the time, and sometimes it's really difficult to detach from all of this and move on to work. And we don't even know when we'd encounter that, and it's unexpected, just like this burn patient here.
Well, you had a normal EKG and chest x-ray, but it looks like you sustained a proximal humerus fracture on the left upper arm.
So, this X-ray shows fracture of the left humerus head, also known as a proximal humerus fracture. It's a common fracture, often occurring in older women after a fall on an outstretched hand. It's a fragility fracture caused due to osteoporosis, meaning decrease in bone mineral density, which is common in postmenopausal women. The fracture here is not displaced, meaning the fractured segments are aligned in their normal position and there's a break in between. This is called a one-part fracture. This means simple conservative management with immobilization of the left arm with slings and pain control with meds.
There goes my backhand. That was a joke, dear.
Okay, because the fracture isn't displaced, the good news is you don't need surgery.
Surgery would only be indicated if the fracture was displaced and broken into multiple parts which weren't aligned, accordingly called 2, 3, or 4-part fractures. Typical surgery for those cases would be open reduction and internal fixation with plates or screws.
Oh, that's a relief.
The bad news is you do need to wear a sling for at least 6 weeks. And I have to insist absolutely no shoulder mobility for the first few weeks.
Immobilization in a fracture is very important for proper healing of the fracture. Immobilization with a sling here would prevent movement at the fracture site and allow bone end to stay in correct alignment and promote callus formation and healing. Also, a fracture can worsen or displace with movement, so immobilization is key here. With all that being said, prolonged immobilization can cause stiffness, frozen shoulder, and muscle atrophy too. That's why early passive movement is encouraged in fractures like the proximal humerus, once pain is under control. Usually, after 2 weeks, we begin the early mobilization phase where the patient continues to use the sling but begins passive range of movement exercises like pendulums or assisted forward flexion, and after 6 weeks, active range of movement exercises are allowed while the sling is weaned off.
And that means you're gonna have to step up even more, because on top of your usual ADLs, you're also gonna have to help your mom bathe, dress, and use the toilet.
I'm so sorry, Mom. This would never have happened if I was more on top of things.
Any more on top, you'd be back in my womb. It's going to be fine.
I know how hard it can be. I was my sister's primary caregiver until a few weeks ago.
Where is she now?
She's in an amazing facility in North Hills.
I know I can be a burden, but I like being in my own home. Just me and my girl.
You're not a burden. You're my mom.
Everybody gets old, and future is unpredictable, which means anything can happen to anybody at any time. So helping your close ones in need becomes a responsibility because you would want the same to be reciprocated when you are in need in the future. Now here, the parent-child relationship means responsibility from both sides. A mother raises a daughter as best as she could, and it was her responsibility. Now at old age, mother becomes the daughter's responsibility. Things can be overwhelming at times, but the caregiver shouldn't feel it as a burden, while the patient should also not feel like they are burdening someone. The caregiver should definitely seek help if needed.
Look, I put in your mom's prescription in at the pharmacy, and by the time you get back from parking, she should be ready to be discharged. Just don't worry. Things will be back to normal in a few weeks.
Yeah, so physiotherapy is very important. During the acute phase, meaning even before 2 weeks, the pendulum exercises could be started as soon as tolerated to prevent frozen shoulder, which means shoulder joint becoming stiff due to immobilization. Early mobilization has to be stressed, especially in older women with osteoporosis, to prevent stiffness and muscle atrophy. She's likely going to be discharged with a sling, pain meds, instructions from the ortho team for physical activity and early mobilization, and follow-up for repeat x-ray after about a week.
I'm not sure what normal is anymore. I can't even remember the last time I slept through the night. It's a lot.
Do you have any support at home?
I wish. It's just us.
You know, I hired a part-time aide for my sister to cover me when I was at work. It was really helpful.
That's out of our price range. I mean, I already work from home, and then there's the cooking and the cleaning and the doctor's appointments. It never ends.
You know, caretaker's fatigue is a real thing.
Caretaker's fatigue is basically a state of physical, mental, and emotional burnout caused by the stress of caregiving over time. The provider usually feels frustration, feeling overwhelmed or helpless, while sometimes guilt for feeling angry and tired or needing a break. There is lack of sleep or downtime, and she has to constantly juggle care with her own personal life while watching a loved one decline. And there is little to no help from others, while sometimes the care provider feels guilty for even asking for help. So the first thing to do here is to ask for help, whether it be calling close ones or a professional help. Also, the care provider has to prioritize self-care and provide time to themselves.
You have to take care of yourself, otherwise you're gonna end up in here too.
You're gonna need to use the antibiotic ointment twice a day and come in for a wound check in 2 days, okay?
The antibiotic ointments given in case of burns would typically be silver sulfadiazine, which is a broad-spectrum antibiotic. Others would be mupirocin or bacitracin, basically given to prevent infection and allow the wound to heal without contamination.
Mateo, can you grab me enough samples to last a couple weeks?
Yeah, I'm on.
Thank you.
Thanks. I really appreciate it.
Yeah, no problem.
Has Kiara been here yet?
No, who's Kiara?
Oh, she's the hospital social worker. She can help you out with like housing and childcare and food insecurity.
You told her?
No,
No, it's all free. The system works if you use it. You
Enough!
have to...
I don't need your help. Nice speech. Next time, mind your own business.
Here the patient feels like their confidentiality has been breached. Doctors do discuss their interactions with patients, often divulging not just medical issues, but also personal issues as well. But the patient would naturally feel like the doctor broke their trust with them if they get a hint that their personal information is overshared. This creates issues with follow-up and even compliance with the prescribed medicines.
You ever heard of impact over intent?
I would never intentionally embarrass anybody.
But you did. You didn't have a conversation with Sherry or ask her what she needed. Instead, you walked in here and told her what to do.
Impact over intent simply means that the effect of our words or actions on a patient matters more than what we meant to do or say. Like, we may not have meant to offend or dismiss someone, but if the impact was hurtful or harmful, that matters more. In this case, the med student here was just trying to help on top of the provided treatment to her wound, but her words, even though soft and kind, indicated a breach in trust with the treating doctor and hence has broken the patient's trust. That's the impact of her words, the broken trust, and only that matters now, not the kindness and positive intent that was laced with it.
You gotta slow down, take a beat, and listen instead of judging people.
Again, the med student here, without building rapport with the patient and discussing her problems, directly came to the conclusion and started preaching solutions to her personal issues. This also came off as rather dismissive or invalidating to the patient, without even talking to the patient first, even though you had no such intent. Of course, the med student isn't judgmental here, but it comes across as judgmental if you directly jump to the conclusions instead of empathizing with the patient first with enough conversations beforehand.
I don't judge.
Please, you've been eyeing me sideways all day.
Even the doctor here feels judged. This just teaches us that we don't directly go around handing out advice in our first few interactions with people without empathizing or building rapport or trust with anyone first, whether it be a patient or a colleague or a senior.
Look, maybe I have a better perspective because I've been on both sides, but we gotta try to at least put ourselves in their shoes. Listening and building trust will make us better doctors and better people.
I'm sorry.
I'm not telling you this to reprimand you. I'm trying to teach you, to help you.
Wait, well, what about Sherry?
I doubt she'll be back. But sadly, there will be many, many more just like her.
As said before, not only there won't be a follow-up, but now the patient won't even take medicines as prescribed. That's how powerful the trust between a doctor and a patient is. This is just a simple case here, but it's important in any case, mostly in patients we see in the outpatient department, where the patient will gladly switch doctors and take second and third opinions if you can win their trust.
Better safe than sorry.
Didn't he just get one few minutes earlier from Dr. Langdon too?
Jake,
Hey,
Where's Teresa?
She went to park the car. Shouldn't have been more than 5 minutes.
Why don't you dial her number for me?
So this is most likely due to the caregiver fatigue. The poor daughter left her mom as she was already overwhelmed with her care, and most likely she couldn't bear the thought of additional ADLs as the mom has suffered a proximal humerus fracture now. This isn't an uncommon occurrence in the hospital and accurately depicts the reality of caregiving and caregiver fatigue in modern society.
Did you pick up?
Straight to voicemail.
That's weird.
Yo. Sole caretaker, overwhelmed, exhausted.
I told her to take a break, but you don't think she ditched her mom, do you?
I mean, it happens.
Jake! There he is. The man, the myth, the legend. The kid stole my concert pass and gave it to a girl. Where is she? Do I get to meet her? Hold that thought, okay?
Travis Johnson, 17, had a tonsillectomy 10 days ago at St. Michael's. Started spitting blood about an hour ago.
Post-tonsillectomy hemorrhage is a serious complication following a tonsillectomy. It involves bleeding from the tonsillar bed after surgical removal of the tonsils. So, the primary hemorrhage occurs within 24 hours of surgery, but this isn't the case here. Since it's 10 days, this is secondary hemorrhage, which typically occurs 5 to 10 days post-operation.
Look at vitals.
Hey, Travis, I'm Dr. Robbie. How much blood?
Couple mouthfuls.
Can you open up for me?
A post-tonsillectomy hemorrhage is usually caused where there is premature separation of the healing eschar or scab from the tonsillar bed at the site of tonsillectomy. This could be due to infection or inflammation. This is common in children who resume solid food too early or have poor hydration. Typically, there would be spitting of bright red blood like in this case.
Hey, Whitaker, Jesse. Got a post-tonsillectomy hemorrhage.
The first thing to do here would be to suction to clear the airway of any blood. The patient is to be held upright, and an IV access is to be made with IV fluid resuscitation. We got a call for ENT consult because most secondary bleeds need to be taken back to the OR for definitive management, where the electrocautery or suture ligation of bleeding vessel can be done under general anesthesia.
Nebulize TXA quick as you can.
TXA means tranexamic acid. It's an antifibrinolytic, meaning it prevents the breakdown of fibrin clots and hence promotes local clot stability in mucosal tissue like here in the tonsillar bed.
Let's go, trauma 2. So this can go south pretty quickly. You up for it?
The main concerning issue would be the airway blockage due to the blood, or if the bleeding can't be stopped and is incessant and there is delay in ENT team arrival, it could lead to hypovolemic shock and the patient might collapse with the bleeder still not identified and taken care of.
Oh, I can. Of course you are. Ready? Here we go. 1, 2, 3.
Tranexamic acid is given here in nebulized form using a jet nebulizer to prevent further bleeding from the site by preventing clot disintegration and stabilizing formed clots in the tonsillar bed.
Take long, slow, deep breaths on that. The TXA is going to help your blood clot.
Hey, any medical problems?
No, just a ton of strep. That's why I had the surgery.
He's referring to streptococcal infections in his throat. While the most common cause of tonsillitis is a viral infection, Streptococcus pyogenes is the most common bacterial cause of tonsillitis. If the patient suffers from recurrent tonsillitis, then a tonsillectomy is considered. In fact, the criteria is 7 or more tonsillitis in the past year, or 5 or more each in the preceding 2 years, or 3 or more each in the preceding 3 years. So, a recurrent tonsillitis with strep led to the tonsillectomy here.
You take aspirin, any other medications?
Aspirin is an antiplatelet. It would cause even more bleeding by preventing clots to form and hence has to be stopped if the patient is taking it.
Lungs are clear bilaterally, no stridor.
Stridor is an abnormal high-pitched breath sound, which is produced by turbulent airflow in the upper airways. This could mean a narrow or obstructed airway. Absence of stridor here signifies no upper airway obstruction due to the ongoing bleeding. Yet,
Okay, sure. You feel like throwing up? Any pain in your belly?
No.
Labs?
CBC, BMP, maybe coags.
CBC or complete blood count is particularly important here to check for hemoglobin levels, which could drop due to the bleeding. A BMP or basic metabolic panel measures levels of glucose, calcium, electrolytes like sodium, potassium, chloride, carbon dioxide, along with blood urea, nitrogen, and creatinine. Coagulation profile is definitely needed to check the coagulation status and whether there is normal function of clotting factors in the patient, which is important to achieve hemostasis.
I had to type and screen just in case.
Yeah.
Type and screen means ABO and RH typing of the blood and screen for antibodies against RBCs, just in case transfusion is required.
Good stats are 98%. BP's 115/80.
Okay, good. 4x4 and a ring forceps. Let's take a look.
Head back, open wide for me.
What do you see?
No active bleeding, but there's some white and dark brown stuff where the tonsils.
So the dark brown stuff that's being referred to in the tonsillar bed is the blood clot that has been formed here. Dried or oxidized blood, meaning blood clots, often appear brownish black. The installation of tranexamic acid has stabilized this clot and not allowed it to further break down and be held there to stop the ongoing bleeding. The white areas he's referring to is the eschar or scab that forms after surgery that we talked about before, which are typically grayish white, the separation of which caused the bleeding in the first place.
Well, that's good. That's a fibrinous clot. That means the TXA is working. Your parents on the way?
They're in Baltimore for a wedding. I didn't want to bother them.
Trust me, they're your parents, and you are in an emergency room. It's never a bother. Write their numbers down, and I will call them. Call ahead and neck. Stay with him until they get here, okay?
This is just temporary management here done using tranexamic acid. The definitive management is identifying the bleeding artery and stopping the bleeding once and for all to prevent recurrence, typically done by ENT surgeons in a surgical setting using either electrocautery or suture.
Good. Pen?
Can I get the... No. He had the surgery at St. Michael's, but he's here now. No, he doesn't have a car. His parents are out of town. Okay, well, how am I supposed to send him back to St. Michael's?
Why is the patient suctioning himself? He could dislodge the formed clot with the suction itself and bleed again.
We'll call him an Uber? You can't... That doesn't make... Hey, hello? Hello?
What's wrong?
They said it is not their job to fix another hospital's problem. Don't worry about it, though. I'll talk to my attending.
The temporary measure has failed here. The clot has dislodged and the patient is still bleeding. This should ideally require surgery to identify the bleeding site and fix it as soon as possible.
Oh, shit! I need a little help here! Okay, come on. You gotta stay on top of Ozzy's ear infection. His meds are in the fridge. Our dog has really bad allergies. And I changed Ruby's food order to Monday. Bougie bitch, she only likes the good stuff.
Mm-hmm. Like mother, like daughter.
So, this is the patient suffering from vaso-occlusive crisis and acute chest syndrome due to sickle cell anemia. She is under exchange transfusion and under IV antibiotics for her acute chest syndrome. The patient still has noisy breathing as shown here. The pulmonary infiltrates shown before could be vaso-occlusive, crisis-related lung inflammation, or pneumonia, or both.
My dad died when I was 13.
I'm so sorry.
Yeah, me too. He's the reason why I got into medicine.
There's often always a backstory as to why people go into the field of medicine or choose to get into med school. Some wanted to be doctors since birth, some fancied being a neurosurgeon at an early age, and there was me who had no such thing at all. I just went into med school because I got my name on it, but learning about medicine and your own body parts and how they function and understanding interesting concepts was what made me absolutely love it, and I always wanted to share whatever I knew and explain things into simple terms, and hence the formation of this YouTube channel that has allowed me to do exactly what I love away from the everyday stresses of the clinical practice. Even the best part of clinical practice for me has always been explaining patients what they are suffering from and trying to make them understand as much as I possibly can.
And the reason why I'm conducting research on racial disparity in the ER. I'm doing a retrospective chart review on our past 5 years of patients of color.
Is that how you knew what was going on with me?
We don't treat sickle cell here as well as they do in other hospitals, but I'm hoping to change that.
Just touching on the medical aspect of this here. Sickle cell anemia is most prevalent in sub-Saharan Africa, and there's a reason for it. The sickle cell trait means one hemoglobin gene codes for HbA, the normal hemoglobin, and the other gene codes for HbS, or abnormal hemoglobin that promotes sickling of RBCs and hence causes occlusion of blood vessels and the disease. Sickle cell trait, or HbAS, offers protection against malaria, which is endemic in sub-Saharan Africa. The malarial parasites can't mature properly in sickle-shaped RBCs, which eventually get destroyed by the spleen destroying the parasites as well. So, the sickle cell gene is passed genetically from one generation to another as a protective trait here. And in countries like the United States, sickle cell is more common among individuals of African descent. Around 1 in 13 African Americans carry the trait, and 1 in 365 are born with sickle cell disease, meaning HBSS state like this patient right here.
Status, Dr. Moya?
Still on exchange transfusion and high-flow nasal oxygen, but oxygen sats are dropping. She's at 84.
That's really low.
Here, the oxygen saturation is very low. The defective hemoglobin HbS has low affinity with oxygen, so the oxygen saturation would be low by itself. But the hypoxia here is mainly because the lungs filled with inflamed fluids have created a barrier for gaseous exchange, hence not allowing oxygen to be delivered from lung spaces to the blood, which causes low oxygen levels in blood and in tissues. Either way, this is not looking good here. A saturation percentage below 90, despite providing supplemental oxygen, is a warning sign, and we might need to switch to better ventilation modes, even requiring intubation here. Also, the exchange transfusion hasn't sufficiently reduced HbS and replaced it with HbA, the normal hemoglobin.
Yes, it is. The goal of exchange transfusion is to reduce the percentage of sickle hemoglobin to under 30%. That is not happening at the rate that your wife needs, which is causing your blood to be unable to carry oxygen, causing further blocked blood cells.
What Dr. Robbie is alluding to is that this lack of oxygen in the blood cells due to any of the reasons mentioned earlier is creating a very interesting vicious cycle here. First, due to vaso-occlusion of blood capillaries in the lung, due to the sickle-shaped RBCs and ischemic damage, there is lung inflammation and hence decreased gaseous exchange and oxygen delivery. Hence, the RBCs are carrying low oxygen, and there is hypoxia. This hypoxia again stimulates the aggregation of the HBS in normal RBCs, hence promoting even more sickling of the RBCs. So, there would be even more sickling and even more vasoocclusion. This vasoocclusion can occur in the lungs again, causing even more ischemic lung damage and even more hypoxia, which again causes even more sickling, and the cycle repeats. Now, an oxygen saturation of 84 means that the ensuing hypoxia is severe and the sickling is rampant in her body. At that rate, she is at high risk of vasoocclusion anywhere in the body. Vasoocclusion of cerebral blood vessels in the brain would cause ischemic stroke, in the coronary arteries of the heart would cause a myocardial infarction, and in the kidneys would cause sickle cell nephropathy and kidney failure. In the bones would cause a vascular necrosis like in the femur head, or sickle cell retinopathy in the eyes. All of this are due to this vicious cycle of hypoxia, hence the oxygen saturation needs to be maintained no matter what.
What does that mean?
Dr. Mohan.
To prevent stroke or heart attack, we need to get you more oxygen, but we'll need to intubate.
How long can we wait to see if that's really necessary?
Acute chest syndrome can progress very quickly. It is the most common cause of death for patients with sickle cell. It is imperative that we intubate.
Intubation has to be done to maintain the oxygen saturation and prevent all the complications of persistent hypoxia and vasoocclusion, all of which is fueled and perpetuated by acute chest syndrome in sickle cell anemia.
I don't know.
Why don't we give you and Ondine some privacy so you can talk?
Look, you want to be their friend, but right now you need to be Joyce's doctor, so get her to sign the consent form and prep for the intubation.
Consent forms are required for every procedure, and it's a tough gig to explain to patients the risks of intubation and how there's a very valid possibility that they could never wake up from it.
Sam Wallace, our good Samaritan who saved a Nepali lady, is in line for a repeat head CT to be sure there's no extension of the interparenchymal bleed.
Okay, so we can dial down the sedation, and if he's alert, check extubation parameters.
This is basically a repeat CT scan to check for whether the intracerebral hemorrhage has extended or whether there are signs of brain herniation or midline shift, which could indicate increased intracranial pressure and requires immediate medical or surgical management. If it's normal, the patient could be extubated.
Copy.
Did you get the consent form signed by Joyce the Sickler for the intubation?
Not yet.
Jesus.
I'm scared. I just want to give her some time to talk
To do what? Make funeral arrangements? Joyce is hypoxic at 84. 84.
Yeah, as said before, saturation at 84 is very low, especially when you add to the fact her disease, that is sickle cell, thrives on low oxygen and gets worse. The vasoocclusion gets rampant and could lead to stroke, heart attack, kidney failure, a vascular necrosis of femur, peripheral vascular disease, retinopathy, and so on, basically affecting every organ that there is until the patient dies of one pathology.
This goes on much longer, she runs the risk of permanent lung damage, heart attack, stroke, death.
I know.
Then move. Now.
Took me all the way back there just to stick a goddamn thermometer in my mouth, you know.
Repeat vitals every 4 hours.
The patient is probably a chronic hospital stayer at this point, where he has learned everything the doctors and nurses say.
Open up. That's a post-tonsillectomy hemorrhage.
Yank out and sponge stick.
He was stable, then it just opened.
Hold the blood bank. 2 units. Hold blood. Get a second line.
Head and neck wouldn't come down to see him.
Assholes.
He's tacky to 120, his sats are down to 90%.
Okay, get a high-flow nasal can.
The patient is profusely bleeding and is likely in a state of hypovolemic or more specifically hemorrhagic shock here, along with decreasing saturation due to the bleeding, potentially obstructing the airway and breathing here. This would ideally require intubation, which would be difficult because the airway and vocal cords are difficult to visualize in case of profuse bleeding. Continuous suction would be required, and even then, it's very tough.
100 of ketamine. Set up the glide scope.
Here, they are going to anesthetize the patient with ketamine and intubate him using a glide scope, which is the video laryngoscope to be used for it.
Hold suction. I'm going to try for direct pressure.
We can pack the tonsillar fossa with gauze pieces temporarily to hopefully reduce the bleeding by applying direct pressure there. The gauze piece can be soaked in epinephrine to cause local vasoconstriction of blood vessels as well.
If head and neck still won't come down, call Garcia.
What all can be done in the ER for this? suctioning, gentle pressure with gauze piece soaked in epinephrine, nebulized tranexamic acid, all these are done here. Now only intubation is left, along with the surgical procedure of identifying a bleeder and ligating or cauterizing it, which is ideally to be done in the OR.
Okay, before we begin, let's take a timeout.
This is Joyce St. Clair. Procedure is endotracheal intubation for hypoxia due to acute chest syndrome. We'll be using video laryngoscopy and an 8OET tube with a 7.5 on standby. Induction with 75 of propofol, 100 rocuronium.
We've seen intubation many times in this series done using video laryngoscopy to visualize the vocal cords. Propofol is a general anesthetic drug, and rocuronium is a muscle relaxant used here to facilitate the process of intubation.
Got it. For backup, we have a bougie and an LMA ready.
A bougie is a slender, flexible tube used to explore, dilate, or guide other instruments within tube-shaped organs like the esophagus, urethra, or trachea. Its common use is in procedures like intubation, where it helps guide the endotracheal tube into the trachea, especially in case of difficult intubation. We all are familiar with LMA or laryngeal mask airway, a supraglottic airway device placed over the vocal cords for use in case of failed intubation or cases awaiting intubation for temporary airway rescue.
Yep.
Any questions or concerns before we start?
I want to be awake.
We can't perform an intubation that way.
I mean, after.
After, we will lighten your sedation. You won't be able to talk, but you can use a pen and paper or an iPad to communicate.
After intubation and the initial general anesthesia, we could lighten the level of sedation, but to be able to write notes and all that, I guess meticulous dosing of anesthetic drugs is required.
I love you.
Till the end of time.
Robbie, trauma 2 right now.
Go with the intubation.
Of course.
What happened?
A bleeder opened up.
Ketamine on board to intubate.
That's holding at 97.
Can you get an airway?
Very difficult to visualize the airway, let alone secure the airway here, all due to the ongoing bleeding that's obstructing everything. If vocal cords can't be seen, intubation can't be done, just like the case of a difficult intubation in episode 2, I guess, where cricothyrotomy was done for it. Let's see what happens here.
Let's lie him down. Keep pressure on the scab. Nothing but blood. Can't see the cords.
SAS 94.
Not sure we have room for the tube with the sponge stick.
If I pull out, there's gonna be even more blood.
Doesn't look like you secured that airway.
We're working on it.
Bougie!
Open a crike tray and prep the neck.
I guess another crike in the setting of a difficult intubation again here. In cases where intubation is difficult or fails, cricothyrotomy is done, which means to make a surgical airway by making an incision between the cartilages of the larynx in the cricothyroid membrane to surgically access the airway below the vocal cords, hence bypassing the obstruction or, more appropriately, the difficult visualization at the level of vocal cords due to bleeding here.
Hold on, I'm going in blind with the bougie. I might be able to feel the tracheal ring.
Going blind with a bougie means he's using a bougie and directly trying to insert it into the vocal cords without its direct visualization. Here, he would be just relying on the tactile feedback to guide the bougie into the vocal cords and the trachea, which would then guide the endotracheal tube into it.
And I might have a three-way with Madonna. Move.
Not happening. Pressure.
Make room for the grown-ups.
Okay, hold on. We can try retrograde intubation.
There's a saying, if you can't see, can't intubate, can't ventilate, then go retrograde. Retrograde intubation is a clever method where you use a needle to access the airway from the neck, pass a wire retrograde, meaning upward through the airway and out of the mouth, and then guide the endotracheal tube over that wire and into the trachea. It's used in difficult intubation cases, or additionally, in cases of limited mouth opening or cervical spine injury. Here, we first identify the cricothyroid membrane, insert a needle to puncture it and enter the trachea, and then advance a guide wire through it upwards from the trachea through the vocal cords and retrieve the wire from the mouth, then pass an endotracheal tube over the wire and into the trachea, then remove the wire and confirm tube placement.
A what?
There's no obstruction. We just can't see what we're doing.
He has got a point though. A cricothyrotomy is done if the airway is physically obstructed due to swelling or edema, as in the case of trauma in episode 2. But if there's just active bleeding and no clots, it isn't a physical obstruction. It's rather a difficult visualization that can be physically bypassed, as a guide wire is easily able to pass through it, which can then guide an endotracheal tube.
So we take a needle, And we put it in the cricothyroid, we run the guide wire up and out the mouth, and we slide the ET tube up over the wire.
Never seen one before. So that's 90.
No time to play MacGyver with this kid. Time to crank.
Did be quick.
A case of retrograde intubation is indeed very rare and isn't really performed that commonly at all. It's more of a plan C, and yes, a cricothyrotomy, which is plan B, is done instead of this if intubation or plan A is difficult.
You got one shot and then I cut.
Even though this process of retrograde intubation suits the patient's airway condition here, the procedure is only ideal in such cases where airway patency is still maintained. If there is no clarity as to if the airway is not visible but patent, or actually obstructed, we can't gamble on a retrograde intubation expecting a somehow patent but not visible airway. Hence a cric is usually the go-to procedure or plan B.
Propofol and rocker on board. Now we wait for the sedative and paralytic to start working.
Should Dr. Robbie be in here?
Between Dr. Mohan and myself, we've done hundreds of these.
I'm getting sleepy.
I'm right here, babe.
They're sedating the patient for intubation here. They are stopping the bleeding temporarily with the direct pressure applied with gauze over the tonsillar bed, while on the other hand, a needle is being used to puncture the cricothyroid membrane between the cricoid and thyroid cartilage of the larynx.
Okay, I'm in.
When the needle successfully punctures the membrane and enters the trachea, there will be a sudden loss of resistance, and air from the trachea will be drawn into the syringe, just like as shown in the scene. This is unbelievable accuracy shown here.
Guide wire. Let me know when you start to feel it up top.
Nothing yet. More suction.
I'm trying.
Still can't find it.
Oh, keep feeling in there. It's gotta be there somewhere.
It's curling up.
So that's down to 89.
Guys, this is not working.
Just give me a second.
The job here is to somehow pass this guide wire through the vocal cords and out of the vocal cords into the mouth. And it's a tough one for sure since the time is ticking. We must note here that if the guide wire irritates the vocal cords enough instead of just passing through it, there could be reflex laryngospasm and the glottis can be closed altogether as well, especially if the patient isn't sedated enough.
Until you rest?
Oh my God.
She's talking about the respiratory or cardiac arrest that could ensue due to the ongoing hypoxia damaging the brainstem controlling the cardiorespiratory centers.
God, I'm gonna lose another patient.
Stop, Whitaker. He's got this.
So that's down to 87.
Okay, I'm gonna redirect the wire.
Sat's still dropping. 86.
You got this.
These whitish structures right here are the vocal cords, the same structures which were difficult to visualize in the bleeding case, and hence intubation, like this, was not possible.
Undine, if you'd like, you can watch on the screen.
Okay.
Excellent view of the cords, Dr. Mohan.
She successfully passed the ET tube, which is this tube right here, into the vocal cords and secured the airway here.
I'm in. Inflate the balloon.
We always auscultate the patient after intubation to check whether the tube went into the trachea and not the esophagus, and also ensure both the lungs are ventilated equally. Sometimes, the tube goes into the right main bronchus, at which point the breath sounds are heard more towards the right. If the breath sounds are equal on both sides, that means that the tube is properly placed.
Good breath sounds bilaterally. That's 92 and rising.
That's it? You're done?
Yes. It all went perfectly.
How long until she gets better?
Depends. It can take anywhere from a few days to a few weeks for the lungs to heal from acute chest syndrome. I can ask the ICU to set up a recliner for you in Joyce's room so you can stay with her.
Thank you both so much.
You're welcome.
Take care.
Since the saturation is up here, the hypoxia is corrected, which means less sickling of RBCs, as sickling of RBCs usually occur as hemoglobin S aggregates under conditions of hypoxia. Now the antibiotics, the anti-inflammatory drugs and pain meds shall subside her acute chest syndrome, hopefully, and she gets extubated soon.
That's 84. We need to bag him. Still not seeing it. Suctioning like crazy.
Okay, we're done playing doctor. Lose the wire. I'm cranking this kid.
All right, we tried. I'm sorry. No, wait. I've got it.
Finally, the guide wire is out of the mouth, which means there is a clear-cut pathway now to put the endotracheal tube inside.
You still don't have an airway.
Keep the laryngoscope in place so the tube passes easily. Pass the T-tube over the wire. Come on. Hang on to that wire. Do not let go of that wire. Okay, I'm gonna give you a little slack so you can get past the cords. Yeah. I feel you at the trachea.
25 centimeters at the lips.
That ought to do it. Pull the wire, bag him. Balloons up.
Yellow on CO2. That's good.
The end-tidal carbon dioxide indicator is a colorimetric device that detects exhaled carbon dioxide to confirm if the endotracheal tube is in the trachea or esophagus. Yellow means exhaled carbon dioxide is adequate, meaning the tube is in the trachea.
Good. That is very good. Good breath sounds bilaterally.
Stats coming up. 90, 92.
Guess you're gonna have to save that scalpel for another day.
You guys got lucky.
No, we got skills, baby. We got skills! Keep gauze on the clot.
Yeah, copy.
Ordering propofol and fentanyl drips.
The ER team has done what it could, securing the airway and temporarily stopping the bleeding by mere pressure over the tonsillar bed. Now it's the time for ENT to step in and do the honors of identifying the vessel and ligating or cauterizing the bleeding vessel in the OR.
Oh, nice of you to join us, Dr. Flores.
Sorry, got stuck in a nasty radical neck dissection. Still bleeding?
Not with direct pressure.
We got the airway, you get the bleeder.
OR standing by.
So I can cancel the Uber?
Let's get him upstairs.
Fresh sponge stick for you, Whitaker. You need me to stay with the...
Your patient did a good job. It's only till the anesthesiologist takes over. You got it?
Yeah, I got it.
Get yourself a fresh pair of scrubs on your way back down.
He has to be in this position, holding the gauze in place there until the patient is shifted all the way into the OR, until the team there takes over. That could take a long time, or it feels like a long time to remain in one position holding the forceps. Even bagging the ambu bag tires you after a while.
I'm sorry that took so long. I was just...
Don't apologize. What you did in there, building a relationship with your patients, earning their trust, it's what this is all about.
Robbie doesn't seem to think so.
Don't worry about him. You know, I should be apologizing to you. Slow-mo, you deserve better. Keep doing you, Dr. Mohan.
It's a commendable showcasing of a doctor-patient relationship. It isn't always this perfect with every patient, and it's impossible to have it, but every doctor tries the best they can to be empathetic and understanding and kind.
Where'd you get that move? Retrograde intubation, that's an Adamson special. I learned that from the best.
Wow, you're not too shabby yourself, Professor.
Yeah, that got kind of rough in there. You kept your composure, though. Exactly the kind of candidate they want for the ED Medical Education Fellowship.
Oh, there's probably over 50 applicants for that one slot.
Yeah, probably. But I know that they like to go with someone that they know from firsthand experience has the skills to be successful. At least that's what I told them in my letter of recommendation.
Thank you.
Now that's a good attending-resident relationship or a mentor-mentee relationship.
Fun. Hey, I know it goes without saying, but please be safe.
I will.
Seriously, don't take anything from anyone. I've already seen 2 fentanyl overdoses today. It's not even noon.
Counterfeit pills laced with fentanyl is a big health problem nowadays. We cannot afford to take anything without a doctor's prescription, or else we might end up losing our lives and hurting our family members instead. Everybody moves on after our death. It's the close ones and families that are left to suffer throughout their lives with our memories.
I promise.
Okay.
Hey, basketball Sunday?
Yep, wouldn't miss it. Hey, before you go.
Please don't hand me a condom.
Condom?
The guy has been handed protection, like there's an epidemic of STDs around here. Jokes aside, people in the medical field will hand out protection to their friends if they find out they're dating, especially if you're not in the medical field. It's a fun banter, but also intended to keep them cautious of the consequences.
Extra cash. You having sex?
Thank you.
Check it out.
Damn! That's in our zone.
Ambulance crashed in our catchment. Get ready for incoming.
How many you think? Other than the driver, no idea.
So there's a mass casualty coming into the ER. Mass casualties always make up for tough working hours. It's the worst if it occurs at midnight ER shift.
So sorry to keep you waiting. I'm Dr. Heather Collins. You must be Christy and Lynette Wheeler?
Yes. Yes, we were supposed to see Dr. Abbott.
I guess this could be the case of the pregnant teen coming for mifepristone, an anti-progestin used in medical termination of pregnancy as alluded by Dr. Jack in the first episode. Mifepristone dislodges the implanted fetus from the uterine wall, and misoprostol stimulates uterine contractions and dilates the cervix for the removal of the fetus.
Yes, Dr. Abbott is an amazing physician, but even he needs sleep occasionally. Okay, I see we're doing a medication abortion today, correct?
Yep.
Well, since I didn't initially assess you, do you mind if I ask a few questions? Get up to speed?
No.
Thanks. Is this your first pregnancy?
Yes.
And you're 17? When did your last menstrual cycle start?
LMP stands for last menstrual period, which refers to the first day of a woman's last menstrual period before she became pregnant. It's an important question to ask as it determines the period of gestation, which is important in a medical abortion. Medical abortion is usually considered most effective and safe up to 12 weeks of pregnancy.
Not exactly sure. End of June. 23rd, maybe?
Any allergies to medication?
No.
Any surgeries in the past?
No.
I need to do another quick ultrasound to make sure everything's okay for the medication. Do you want to put on a gown to make sure you don't get gel all over your clothes?
Since the history of LMP isn't quite reliable here, or at least it looks like so, as the girl is uncertain here, an ultrasound is typically to be done here to determine the gestational age, that means the duration of the pregnancy. Ultrasound helps to accurately measure the size of the embryo or fetus and determine the gestational age. This is helpful because medical abortion is most effective up to 10 weeks, and its success decreases after 12 weeks. An ultrasound also helps to confirm that the pregnancy is intrauterine, that is inside the uterus, rather than ectopic, that is outside the uterus, usually in the fallopian tubes. An ectopic pregnancy is a medical emergency and cannot be terminated with medical abortion and requires immediate surgery. Ultrasound also helps to rule out other conditions such as fibroids, ovarian cysts, or other abnormal growths which might interfere with the abortion process. So these are all what she meant when she said the purpose of ultrasound was to make sure everything's okay.
Okay.
I'll be right back.
Thank you.
A little jelly on the belly? Sorry, it's cold.
She's performing an ultrasound before medical abortion to check for the gestational age and confirm that the pregnancy is intrauterine and not ectopic, and also rule out any other abnormality.
And just to be sure you're not being treated for any blood clots, taking any anticoagulants?
So it's very important to ask this because medical abortion does cause heavy bleeding, especially after taking misoprostol during the expulsion of fetus. If patient is on anticoagulation, it significantly increases the risk of excessive hemorrhage and patient to go into hypovolemic or specifically hemorrhagic shock from profuse bleeding here, requiring blood transfusions.
No, I don't take any medicines.
So this is an ultrasound of a normal fetus inside the uterus.
Is everything okay?
Yeah. Christy Wheeler, 17 years old, pregnant. These are Abbott's fetal measurements from yesterday, and these are mine.
10.5 and 11.2. Wow, ultrasound is an art, not a science. Even in the very best hands, the EGA differential can be within 3 to 5 days in the first trimester.
EGA means estimated gestational age, which means the age of the pregnancy, which is calculated here using ultrasound. For this, different measurements of the fetus are taken by ultrasound like crown rump length or CRL, which is the most accurate for the first trimester to determine the gestational age. It simply means the measurement of a fetus's length from the top of their head to the bottom of their buttocks. BPD, or biparietal diameter of the fetal head, can also be taken, along with femur length and head and abdominal circumference, usually in the second trimester, where we usually perform ultrasound dating scan. Now, these measurements are tallied up in ultrasound to determine the estimated gestational age. For CRL, usually there is an error margin of about 5 to 7 days. The mean gestational sac diameter could also be measured early on, but isn't that reliable. CRL is the one to be looked for here.
Definitely room for error.
Not if you're here for medication abortion and you're past the mandated 11-week cutoff.
Oh, so here the gestational age is beyond 10 weeks. In the United States, the FDA has approved the use of mifepristone for medical abortion up to 70 days or 10 weeks of gestation. It's important to note that abortion laws vary by state. However, the point here is beyond 10 weeks, the safety and efficacy or success of medical abortion decreases. As the age of gestation increases, there is slightly increased risk of incomplete abortion and heavy bleeding, and it could pose a risk to the woman's physical or mental health.
There can also be interoperator variability.
I measured the gestational sac 11.3 and the fibroidal diameter 11.1.
This means the gestational sac diameter and the BPD measurements here indicated that the gestational age was 11 weeks and 3 days and 11 weeks and 1 day respectively. Dr. Jack's measurements alluded to it being 10 weeks and 5 days. Important thing to note here is that the mean gestational sac diameter doesn't hold that much value here. It would only hold value if the pregnancy was below 6 weeks, at which point the CRL couldn't be measured. But here, the CRL can be measured, so that should be the one determining the gestational age.
I didn't get a single measurement under 11 weeks.
So what are you saying, that Abbott lowballed his measurements to help a teen get the abortion that she wants?
Maybe.
Well, then you've got two choices. You can go with Abbott's measurements, or you can redo your measurements, go back in and pick an angle that shows 11 weeks or less.
This is a completely unexpected turn of events. Is this turning into a political debate where one is for it and the other is against it, and hence the difference in opinions? Interestingly, the scene is created where the USG measurements are exactly hovering over the said mandate of 11 weeks. An error of 5 to 7 days is expected, even with the best measurement at that age, which is the crown rump length. Let's see what happens.
Please tell me you're joking.
You were ready to roll up your sleeves and arm wrestle the ethics committee a couple hours ago to override Mr. Spencer's children. What changed?
Apples and oranges. There was a clear, bright line that Mr. Spencer was never going to make it.
She does have a point. Intubation and ventilation was a mistake at the end stage of the patient's life, and that was eventually undone by extubation.
Falsifying medical records for Christy is flat out illegal.
She's 17. She deserves a life.
Of course she does. But I will not jeopardize my future in the process.
You'll be fine.
Someone finds out I falsified medical records, I'll get booted from the residency program. You've got tenure. Worst case, you have to take a job in Youngstown. The risks are not the same for you as they are for me.
First of all, the measurements here aren't that far. 10 weeks and 5 days of Dr. Jack versus 11 weeks and 1 day for her. Second of all, I wouldn't want to go into the political debate for this. As doctors, we would want the teen's health to be taken care of as the #1 priority, with no complications occurring during and after the abortion process, if that happens here. The complications of abortion could be heavy bleeding, incomplete abortion, or sepsis due to the retained products of conception.
You're right. I'll do it.
What?
Erase your history, physical, and impression from Christy's chart and be like you never saw the patient. I will take over. I will complete a new chart and upload my own image.
Robbie, I'm not asking you to...
As your attending, it is my decision. I am a certified provider for mifepristone. You are not. And as a prudent physician, I should examine every patient before I order.
Again, an unexpected turn of events. Whether it's trying to encourage a peaceful death, or trying to help a young child with violent ideations get the necessary help he needs, or whether it's trying to restore the teen's life, it's undeniable that Dr. Robbie is not hesitant to go beyond the standard norms to help people's lives here.
I still don't understand why Christy needs to go through this a third time with a third doctor.
Yeah, that's our bad. Our computerized medical records have been glitching lately, and Dr. Collins' image didn't upload properly. Okay, crown to rump. That's top of the head to the bottom of the butt. It's how you measure gestational age, and we are at 10 weeks and 6 days.
We've already discussed crown rump length before as the most accurate and reliable measurement for estimating gestational age of fetus. The resident was holding on to the gestational sac measurement, which doesn't hold value after 6 weeks when CRL becomes measurable, and another measurement, the biparietal diameter, is reliable in the second trimester, meaning beyond 12 weeks.
I made it by 1 day.
I will order the medication. Dr. Collins will go over instructions on taking the pills when we come back from the pharmacy.
Thank you so much, Dr.
Oh,
Robbie.
I'm glad I could help. Even more glad to see you have such a supportive mom.
A little bit about medical abortion here. Where I work, the protocol says to take a tablet of mifepristone 200 milligrams followed by 800 micrograms of misoprostol 24 to 48 hours later. Misoprostol can be administered buccally, that is placed between the cheek and gum, intravaginally or sublingually, that means placed under the tongue. Mifepristone, acting as an antiprogestin, dislodges the implanted fetus and makes the uterine environment unfavorable for continuation of pregnancy by blocking the progesterone hormone receptors, while misoprostol is a prostaglandin which helps stimulate uterine contractions and dilate the cervix for the expulsion of the dead fetus outside of the vagina via heavy bleeding.
Okay, take care.
Appreciate you stepping up.
All good. I got you.
Robbie, Emma Isaac's on line 3 for you. She's the organ donation counselor coming to speak to next parents.
The brain-dead child is being considered for organ donation here if the family consents. Even though his brain has died, the ventilation is keeping his respiration and heart going to prevent hypoxia and preserve organs from hypoxic damage that could then be donated.
What's that all about?
Oh, nothing.
Didn't look like nothing. Why do you two or what's a thing?
We dated briefly 1,000,000 years ago. Never again.
Never say never.
Settle down, Jane Austen.
The lady doth protest too much.
Again, another unexpected revelation here. I've been wondering throughout the previous episodes why the resident is talking to the attending as if he were her friend. Usually there is no pushback or questioning to your attending unless it's a big issue. So this makes all the sense now that they talk like equals and not junior senior.
Since your past 10 weeks, you'll need to take mifepristone twice. Once now and once in 24 hours.
We briefly touched on the protocol for medical abortion and its mechanism of termination of pregnancy before. Mifepristone 200 milligrams, and then after 24 to 48 hours, it's followed by 800 micrograms of misoprostol to be taken sublingually or buccally or intravaginally. However, I have never heard of taking mifepristone twice. At least that's not done where I work and live. But from my understanding, misoprostol is the one which can be repeated if it's not effective. After 10 weeks, the success rate of medical abortion decreases, and so there could be risk of incomplete abortion and retained products of conception. That's why, after 10 weeks, repeat doses of misoprostol could be required. 800 micrograms of misoprostol could be repeated every 3 hours for a maximum of 3 to 5 doses to ensure complete expulsion of fetus.
Then 24 hours after that, you'll take misoprostol, 2 pills which dissolve between the cheek and the gum. Then 2 more of the same pill 6 hours later.
Just a note here, the 4 pills containing 200 micrograms of misoprostol can be taken altogether. Secondly, here the Bacterial route is explained meaning putting medicine between the gum and cheek, but sublingual under the tongue can also be given or intravaginal routes as well.
It's a lot to remember.
Everything is clearly labeled with the names of the meds, the dose, and the exact time to take them.
Will it hurt?
You can expect some vaginal bleeding. There may be some cramping, like when you're on your period.
Bleeding is expected in abortion since it involves the expulsion of a fetus which was dislodged from the uterine wall.
If you're bleeding more than 2 pads an hour, or the pain gets to be too much, come back in and see us.
And I'll be with you the whole time.
Heavy bleeding involving soakage of multiple pads or passage of clots has to be taken care of in the hospital via fluid resuscitation to prevent the patient from going into hypovolemic shock due to loss of blood volume.
Christy! What the hell are you doing here?
Language. And I should be asking you the same thing.
Excuse me, who are you?
I'm her mom.
Mom? Aren't you her mom?
I can explain. No, that's my sister, Lynette. I am Christy's mother. Chris, baby, what are you doing here?
Unexpected turn of events again. The girl, as mentioned by Dr. Robbie earlier, is just 17, which means she is a minor and her aunt is not her parent. This could have legal implications here.
I'm here for an abortion.
Did you do it already?
Not yet.
Okay, thank God.
Okay. Can we all just take a step back here?
Mom, I want this. This is my decision.
The abortion of a minor depends upon the laws of abortion, which varies from state to state. Some states demand a parental notification, meaning that the minor must inform a parent but doesn't need their approval. Some require parental consent, meaning permission from a parent. Some have the option for judicial bypass, meaning the minor can ask a judge for permission without involving parents. Some states have no requirement, meaning minor can get an abortion without parental involvement.
No, just listen to her. Okay, shut up! You have done enough. My daughter is a minor, so she can't get this abortion without my say-so, right?
In Pittsburgh, Pennsylvania, the law mandates that an unemancipated minor must obtain informed consent from at least one parent or legal guardian before an abortion can be performed.
Is that right?
That's correct.
Then there is no way this is happening. Not now, not ever.
Now, if a minor cannot obtain parental consent, they do have the legal right to seek a judicial bypass in the court of law,